As we aim to get the right material for our patients with non-small cell lung cancer and identify all of the predictive biomarkers, it's really a team effort, and we have to work together, whether it's an interventional radiologist, surgeon, pulmonologist, oncologist, whoever is requesting the biopsy, whoever is doing the biopsy, and extremely importantly, we need to have the perspective of the pathologists always brought into all this. Now, with all these people involved, the biggest challenge is communication. When our pathologists get a tissue sample from the interventionalist, they don't know what it's going to be used for. And if they don't know what it's going to be used for, they can't process the tissue appropriately. I think one of the best examples of this is bone biopsies. When we do bone biopsies, we can't, if we want to do molecular testing from a bone biopsy, that sample can't be decalcified. But decalcification is a routine process in pathology of bone biopsies. And so as a consequence, that communication needs to happen immediately from the requesting physician. So when you ask the interventional radiologist for a biopsy, you have to tell them that you want to do molecular testing if that's your goal. And if they're going to do molecular testing, then that interventional radiologist has to let the pathologist know that you want to do molecular testing, and so they shouldn't decalcify that specimen. It's critical that everybody know what the ultimate goal for that biopsy procedure is. And when everybody knows the ultimate goal, everybody can get the right piece of material, a piece of tissue, and they can do the best thing for the patient. With the difficulties in getting tissue that we need to determine all the predictive biomarkers, many people have explored the idea of using circulating tumor DNA or circulating tumor cells. This is very much in infancy in patients with non-small cell lung cancer. We don't have a lot of data to say that the methods are good and any particular method is the best, but I think we're learning a lot about this method, and in particular circulating tumor DNA. And what we're looking for in circulating tumor DNA assays is, and this is sometimes referred to as a liquid biopsy or plasma biopsy, we're taking patients' blood and actually getting rid of all the white blood cells, red blood cells, and looking only in the plasma to look for pieces of DNA that have been shed from the tumor. Very sensitive DNA sequencing techniques can identify those bits of DNA. In about 60% of people with non-small cell lung cancer, we can identify those bits of DNA and find the mutations that are driving those tumors. So if you're looking for an EGFR mutation and your tumor sample isn't good enough to do mutation testing, one pathway forward may be to use a plasma biopsy or a plasma test for circulating tumor DNA to find EGFR mutations. Again, this is very much in its infancy. There are probably more tests out there that are developed than the ones that are really good, but I think it's definitely an exciting area, and we certainly look for more data in that area.